Welcome, everyone. I welcome you to Grand Rounds here at Silver Hill Hospital. For those of you who don't know me, my name is Andrew Gerber. I'm the president and medical director, and it is a special honor for me to be here today to introduce our Grand Rounds speaker, who is a very, very special person here at Silver Hill, and that is Rocco, as those of us who know him well call him Rocky Marotta. A wonderful psychiatrist, physician leader, researcher, and all around a brilliant clinician who we are very, very fortunate to have here at Silver Hill Hospital. I'm going to tell you a little bit about Rocky's background before turning it over to Amir Garakhani, our Director of Education, for some more personal words about Dr. Marotta, with whom he's worked for many years. So Rocky has a very unique background. And one that I think we are particularly fortunate at Silver Hill to have. Rocky originally trained as a neuropsychologist at City College in New York, and is well steeped in the ideas and the principles that psychology and neuropsychology bring to the field, also the mind of a researcher, as that was an early part of his career. He then did a medical training and did his psychiatric training at Payne Whitney Cornell, which some of you may know is where I trained as well. So we have a special connection and affinity over the kind of learning that he got at Payne Whitney. He worked at New York Medical College in Valhalla before becoming an assistant professor at Columbia, and then as well as at Teachers College, also part of Columbia, and is now an associate clinical professor in the Department of Psychiatry at Yale as an adjunct, and is connected there as well. He has been involved in many activities over the course of his long and productive career, but I did want to highlight a couple very important ones. That for several years he was the assistant unit chief and then the unit chief of inpatient services at St. Luke's Roosevelt in New York in their psychiatry department. Then the director of their entire inpatient service, and ultimately the director of inpatient psychiatry at Danbury Hospital here in Connecticut as well, before becoming the chief of the medical psychiatric unit at New York Medical College, Westchester Medical Center. So he has an enormous amount of experience working with patients of all kinds. But what he's done here at Silver Hill over the last 11 years is particularly amazing, because he has built a program which we refer to as Michael's House, but as others know, more recently now as a Center for Neuropsychiatric Disorders. And he's built it into one of the premier programs in the country, if not in the world, at treating individuals, particularly younger adults, with new onset neuropsychiatric difficulties, in particular those with bipolar disorder that has been refractory to other treatments, as well as early psychotic disorders. And people really come from all over the country for the kind of expertise that Rocky and his amazing team offer. And I'm sure you'll hear more about his team today, because Rocky humbly credits them as well, and they really do all deserve credit. But Rocky is their inspiration and their leader, I think, as they would all tell you. And he has built something quite unique. Just over the last year, starting just before COVID hit, we have been working closely with Rocky and one or two major donors to build this Center for Neuropsychiatric Disorders into something larger than a clinical service, but one that really builds on Rocky's research and the priority of educating clinicians and people in our field about the kinds of results and work that Rocky does. There's so much we can do, even beyond the walls of Silver Hill, based on the work that Rocky is doing and that he has been publishing and that you're going to hear about today. So it's a very exciting time for us. I admit that COVID did slow us down a little bit in the development of this center, but we are back at it now. And I hope that all of you who are interested get in touch with us. We're looking for folks who are interested in supporting our work, and look forward to telling you a lot more about what this center will do in the coming weeks, months, and years. We already have a couple terrific hires. Rocky will probably mention Dr. Meriwether Brown, who is a psychiatrist he works closely with, as well as research coordinators who are making this research happen and helping us spread this work more broadly. So I'm going to stop there because I could probably go on for the whole hour and a half just to talk about Rocky, but you're here to hear about his work. But before we do that, I do want to turn it over to Dr. Garikani, who's going to say a little bit more about Rocky before his presentation begins. Dr. Garikani.
Thank you, Dr. Gerber. I wanted to first start off with a little bit of housekeeping. The grand rounds today will be roughly an hour of speaking, and then we'll have time for questions, about 15 minutes of questions at the end, where you can submit the questions through the Q&A bubble. You can see that at the bottom, and we'll try to get to as many questions as we can. There'll be more of a kind of a lively discussion where Dr. Marotta and I will discuss, and Dr. Gerber will join us any questions that may come in. And in addition, if you want CME or CEC credits, you can wait for the browser to open up. There'll be a survey that you need to fill out, or it'll be emailed to you. I want to thank everybody for attending the grand rounds. We have a lot of really exciting grand rounds coming up over the next few weeks. Dr. Robert Ostroff from Yale is coming next week, and it's just going to be, week after week, some really great programs. But on a personal level, I wanted to just say that Dr. Marotta and I have worked together in the transitional living programs here for many years. I started Silverhill in 2008, around the time Dr. Marotta started as well. But I was working in admissions, and I remember that Rocky would come down to admissions sometimes to see his patients, and I can say cantankerous is one way I would describe him. It was always interesting seeing him, and it wasn't until I had a chance to work with him side by side in the transitional living that I really understood just the depths to which he would go to for his patients, the links. I mean, he had such a bond with the patients who came into Michael's house, and I firsthand got to see just the impact that his work was doing on their lives by covering. And occasionally when Dr. Marotta would take a vacation, but of course the vacation for him wasn't really a vacation because he would still be available and talking to the families and the patients by phone. But when I did cover, I was just amazed at how much impact that he was having on their lives, and positive impact. And I could see patients who had come in and out of hospitals and treatment facilities who were able to get back to work. And I think that, yes, Rocky is going to talk about the work of using oxytocin with clozapine. And I've seen the impact that his work has done with the treatments, but I also think it's the personal touch and the caring that he brings to the work that inspires me. And, Dr. Marotta is the kind of doctor that I want to be when I grow up, if I ever grow up. But I want to say that I really think that whatever the things we're discussing today are really just a springboard for amazing work that's going to have to continue on a larger scale. And I'm going to be part of that work. And I hope that Rocky and I can continue to expand with our group on the research that we've already started, and some of it's already been published. But let me stop talking and hand it over to Dr. Marotta.
Thank you, Amir. You're going to make me cry, both of you. I don't know what to say, so I'm going to jump into this. I have a lot of slides here, and the reason we put this together with a lot of slides is so it could be downloaded and you could follow some of the logic or mislogic we've put together and some of the data, because presentations like this go pretty fast. But what I'm going to present emerges from hard work of a lot of people, hard work, collaboration of the whole clinical and administrative staff here at Silverhill, and especially the Transitional Living Program and the Michael's House program. And there's another thing, because this is the real world. It's been critically dependent on the financial support and encouragement of our friends in the Calico family and the Newhouse family, and Dr. Feiner and his family, and also my secret cooking companions. We share recipes, Audrey and Richard Zinman. And then there's all these special colleagues I have here. Dr. Bono and Yale at Dr. Bono and Dr. Ball at Yale, Dr. Rowe and Dr. Garikani, who are like, I guess, sons to me now, and Dr. Beal, Dr. Doherty, who are my whips and organizers. I would, get nothing done around here without them. And then the clinical staff, Wallace Stacy, Emily Day, Cortina, Emma, Francis, Katie. There's so many, the two Lises, Heather, Joseph. if I was trying to put together a list, I was one of those, like those poor guys at the Academy Awards are being pushed off the stage, you know, there's just so many, and I don't want to leave anybody out, but they are absolutely necessary for the well-being of the patients and the families. They all deserve so many silver stars and gold stars. We really can't thank them enough. And of course, there's something else, because I wouldn't even get here if my therapist, my long-term therapist, Dr. Lisa Mann, didn't get me out of the house, keep me fed and related, and my other children, my beloved children and grandchildren and extended family who always take care of me. And I have to thank all of them for getting me here. Now, I'm supposed to say I have no disclosures. We've gained no direct financial support from this. The thing I want to say again and again is I've been very focused on the neuropharmacology and the medical aspects, but nothing would get done around here without this clinical staff caring for the patients and the families and the inputs from our families and their concern for their children. I had to show this. This is Da Vinci, right? This is biological psychiatry had a whole issue on oxytocin a few years ago. And so it's not just me coming out of nowhere. All over the country and the world now, there's literally several thousand papers have been published. And the Garicani and I have been trouble keeping up with this because we're trying to write a review article with Dr. Bono, and we can never catch up. There's so much data coming out, but we have I think a special kind of data to present to you. This is what is now Michael's house. It's a building on the campus. We've been through 5 different sites in the last 11 years. We're, wandering Jews in a way, but this is, people live here 24 hours a day. There's a large treatment staff. People stay here at least 6 weeks, sometimes much longer. The focus in the house is remediation, learning social skills, learning to be nice to each other, while we also try to change medicines and get people well. So just so you see, it is an actual place. And usually we have up to 14 patients, so it's a busy place. Now, we deal with people with severe neuropsychiatric disorders. So bipolars who don't respond, sometimes brain damage, bipolars, and lots of people with schizophrenia. I'll use the term schizophrenic symptom disorders. So schizophrenia or schizoaffective. So I just want to frame it a little bit by talking a little about schizophrenia. Is a terrible illness. One of its old names, from the early 20th century was dementia praecox, which means a dementing illness of the young. It's characterized by an onset at around 18 years of age in most countries up to recently, but now maybe earlier because of the stress in our culture and the amount of drug use. It has positive symptoms, negative symptoms, and general cognitive symptoms. This is everything I'll talk about this is a little overly simplified, but people are delusional, they have hallucinations, they have disordered thinking and speech. Those are positive kinds of things. And there's negative things like reduced motivation, lack of emotional display, not making eye contact, not speaking very much, loss of interest in daily activities. And this can look a little like depression too, and maybe a part of a depressive thing, a brain disease. And then there are cognitive problems, right? Difficulty making decisions, difficulty maintaining focus, and people then leave school because of it. They can't work or be in school with these kinds of symptoms. Now, people have this illness. It's a form of suffering. I like to use the word suffering because it is a suffering, right? People are not living the kinds of lives that you want them to live. They don't reach happiness. They don't have the usual lifespan. They may, the average lifespan may be 15 years less than people who don't have this kind of illness. And there are over 3.5 million people supposedly in this country alone with this diagnosis. Now, over 50 years ago, medications were found that help with it. They help mostly with the positive symptoms. French military surgeons who were treating patients found that if they used certain drugs with names like promazine and chlorpromazines that were related to aniline dye structures, not only calm patients before surgery, but also would modulate psychotic symptoms. And so that led to the whole explosion of modern psychiatry and developing drugs called first and second generation antipsychotics. Now, these drugs are all very good for the positive symptoms, but not so good for the cognitive symptoms or the negative symptoms. There is one medication that's a little different. It's called Clozapine, and we'll talk a little bit about Clozapine, because the real issue is this. You can have patients who get better, and the insurance companies will send them home, but they still do not have really complete lives. They're socially isolated and don't do so well. And maybe over 60% of people diagnosed with schizophrenia don't return to a normal functioning life. It may be as high as 80%. So these patients are treatment resistant in some ways or not fully responsive, right? And it's more the negative symptoms, the cognitive deficits that persist over time. And so that really is our target. What can help with that? And that takes us to this whole idea of what may be going on, right? So in my mind, schizophrenia is not because you were a bad mother or something like that, but it's a terrible illness, which is a brain illness. And there are genetic factors of vulnerability, and there are environmental factors like, having had brain damage or maybe being exposed to a toxin or having a viral infection at a critical period. We have a sense that there's a dysregulation of certain critical systems of the brain, such as the dopamine system, but also a dysfunction of the NMDA or glutamate system. And because of this, in this disorder, there's defects of sensory defects, defects of thought, of cognition, the development of negative symptoms. There's a complex interaction, and there are theories about these neurotransmitters in the brain and the drugs that affect them. But they're all very complicated because the brain is a very complicated structure with overlapping inputs. But again, we're talking about 1% of the population maybe having this illness, and 50% of those patients not really responding well enough to go back to a normal life. So of all the medications we have, only Clozapine seems to be different in that occasionally some people seem to be cured, right? And you've heard about them, some of these people, because they've written books and they've been studied in the New York Times, but also a very large percentage of people on Clozapine show a marked improvement. And so this is a slide taken from what's called the CATI study, comparing Clozapine to some of the other antipsychotics using the same rating scales we use here called the PANS, the positive and negative symptoms scales, right? Showing, just so you get an idea of it, that the Clozapine is better. You get, an 11-point to 12-point increase over months. It's slow, but it's real. Now, what's interesting about it is you'd say, well, most of, medicine, if you had a treatment that was so much better than others, why wouldn't everybody be on it? Well, if there was a better treatment for breast cancer or for prostate cancer or congestive heart failure, people would be on it no matter what the cost. And so for some reason, that's not true in psychiatry. Clozapine, it works well, it works best, it improves cognition, it has anti-aggressive properties, it's a good antipsychotic, it's a good mood stabilizer. It decreases suicide rates, and suicide rates are fairly high in schizophrenic patients. But this is the but. There's a risk of a granulocytosis, so the dropping of neutrophils, which is white blood cell, making people prone to infection. It's 1 person in 100, roughly, so that there's a hesitation to using it. The other risks, like weight gain, high lipids, and seizures, are like all the other drugs. They all run those risks. The granulocytosis is a special risk. And so it requires that the medical staff follow the patients carefully, follow rules, get blood tests, and it takes it's a more intensive treatment to start patients on this treatment. But it's a good mood stabilizer. the reducing rates of relapse is incredibly important. It's also used to treat some of the side effects of the other medicines. This to me is all spectacularly important. I mean, if you have 3.5 million people diagnosed with schizophrenia in the United States, you have a cost that's estimated at something in the range of like $155 to $160 billion a year. And much of that cost is for those treatment-resistant patients. The average, cost to treating a treatment-resistant patient in this country is over $60,000 a year. So the range is between $66,000 and $160,000 a year. That's an enormous cost financially, in addition to this very high morbidity and mortality rate. Just parenthetically, to stay at Michael's house for a couple of months for us to work with people takes around $65,000 roughly. So it might be a good investment if you can get a patient from the $160,000 a year cost down to maybe the $20,000 a year cost, not to mention getting people a lot better. But these patients have high rates of cardiovascular disease, drug abuse, suicide. So this is a very high risk population in terms of morbidity. And I think this morning there was a report that COVID has a higher morbidity and mortality in schizophrenics too. So we're talking that this is a general thing. Now, if you have drugs that only partially work, what a good doctor is going to do? They're going to try to figure out how to make them work better. And one way of doing that is to add on other treatments. So since I've been focused on the more biological interventions, among them are, methadone, Suboxone, electroconvulsive therapy, mixing multiple antipsychotics, adding lithium, adding antidepressants, stimulants of all kinds, all vitamins, hormones, antibiotics, aspirin, Motrin. I've tried all of these over the last 20 years. And occasionally someone does get a lot better on it, but there's been no pattern. I've never found a add-on to the antipsychotics in general or to clozapine that really made a huge difference. Clozapine better than the others, but nothing at all. So I've spent 15, almost 20 years now trying to break through this. And so I'll tell you a little story about what began to happen to break through. I was raised, in the old Catholic faith. So, in an Irish parish. So old Monsignor McQueenie would yell at us boys and say, Time Jesum, beware that Jesus appears and you ignore him, I think that's a general phenomenon that the truth there, something appears that you should have paid attention to and people didn't. This is one of my favorites, it's a letter from Dr. Budenow, right, in Leningrad, now St. Petersburg, to the Lancet, which is a journal in London, saying, I want you guys to know that I've started treating schizophrenics with oxytocin and it really works. He wrote them twice and no one picked up on it, who knows? But he had some ideas and it just wasn't picked up on. Jesus passed, they didn't notice. Around this, a little after this, I was sitting in a lecture hall at Cornell at the medical school. And we had a lecture from Dr. Vincent Divino's group. They had won the Nobel Prize for studying oxytocin. I don't know how much attention my class paid to it. There was a lot of detail about the neurochemistry. But, I guess those ideas were put in my head. I didn't see the letters, obviously. I only found them many, many years later. Oxytocin is a hormone. It's produced by the hypothalamus. It's an interesting hormone. So neural cells produce it. They go to the posterior pituitary and they release it like a hormone. But it's more than that. It also gets released from the dendrites of these cells. They're called magnocellular and diffuse within the brain. And in addition to that, it gives off long axons that release it. So this is an interesting thing, that you have certain cells in a specific part of the brain that release a chemical as a hormone and also use it as a widely distributed neurotransmitter or neuromodulator. and it connects to many of the most critical parts of the brain in the neurochemical subsystems. Again, this would be hours of a seminar to discuss this, but I just want to put that in all our heads. And it's involved in everything from wound healing, inflammation, pain relief, right? Because it raises the pain threshold. It's major hormone in the birth of children because it's what's produced when a baby is born, right? It also is what's produced to allow a mother to release milk. Mothers feel they go into a state of what? Happiness, nirvana, pleasure when they breastfeed, and also when they give birth. And some people think that the oxytocin itself is part of it. It regulates homeostasis in general. It looks like from certain high-level research, which was just published a few weeks ago, that it can be used to treat congestive heart failure because it induces parasympathetic tone. It almost does too much. I mean, how can you believe that one chemical can do all these things? But why did we get into it? Well, not because of schizophrenia. So we had a young woman in our program in the TLP, but not in Michael's house, who had been struggling with horrible substance abuse problems. And even sober, something seemed wrong. She just wasn't as related as one thought she would be. Highly intelligent person, well-educated, and something was off. And she looked to me like she was almost autistic, though by history she wasn't autistic. And what it led to is my trying to figure out what was going on and doing a neuro exam and then getting an MRI. And we discovered that she had a vascular abnormality of a right frontal lobe, which was acting like a point of pressure, like a small tumor. Spoke to Dr. Fink at Cornell in the Department of Neurology and decided that we wouldn't touch it, but I had to find a way to treat her. And then Dr. Ackerman's wife, is a famous doctor treating autistic patients. So occasionally we talk about the autism literature, and some people were trying oxytocin on autism, including Dr. Hollander, who was chair at Mount Sinai. He was actually using IV just like the Russians had used, I guess, 30 years before him, and having some interesting data. So I thought, well, maybe this patient has something like, I don't know, brain pressure induced autism. And I decided I'd give her some oxytocin. But since she was in a program for substance abusers, I didn't want to give intranasal oxytocin, which is what everybody else had been using, because I thought it would sort of trigger drug abuse again, snorting drugs. So we contacted some people and got a pharmacy to make us a form of oxytocin in a wafer that could be put under the tongue. So a sublingual oxytocin preparation. And this patient got better. So I thought we had found something that was useful in people with frontal lobe damage maybe, but we weren't seeing lots of them and we were so backed up with other stuff. And I didn't immediately make a kind of connection that I might have. This is just some more information about oxytocin that you might look at. It's involved in social processes, pro-social, emotional regulation. So that's why it kind of worked, I thought, with the patients who were showing autism. But other people thought that it might be useful in schizophrenia. So this is 2021, 19, right? So people began noticing it a few years ago. There was something going on, all right? Now, this cartoon is of the brain. It's very, very simplified. If you can see it clearly, it's just that the pathways for dopamine and the pathways for, the dopamine system, the glutamate system, and the oxytocin system overlap. And that's more to the lower right. I tried to put them in different colors so you get a sense of them. It doesn't come out so clearly, unfortunately. It is something else that overlaps, which is the innervation of the nucleus basalis of Minor, which is the system that degenerates in Alzheimer's disease. It also has a very high density of oxytocin receptors. So the oxytocin system in the brain overlaps with the system subserving cognition and emotional tone and regulation, going up into the frontal lobe, the hippocampus, the amygdala, the anterior commensurate nuclei, the anterior cingulate, et cetera, and the septum, because why not? Since I did my Ph.D. thesis on the septal nuclei, why couldn't it be there too, right? Everything is coming back. That's a system in which dopamine overlaps with oxytocin, it seems now. So, but these are complex circuits. We would, again, take hours to go over, all right? But just to beat the horse, it's the oxytocin receptors and distribution system are all over the brain. They overlap with the dopamine. It overlaps with glutamate, which is really the most ubiquitous of all transmitters. 90% of the cells of the brain use glutamate in some fashion, all right? But just some ideas. Oxytocin decreases cocaine-induced hyperactivity, as does some antipsychotics. Oxytocin decreases methamphetamine-induced hyperactivity. Chronic PCP use, which can induce a psychosis looking like schizophrenia, decreases the hypothalamic oxytocin. Oxytocin into the central amygdala, which is involved in emotional expression, right? Reduces the PCP-induced social withdrawal, which is a animal model of schizophrenia. Clozapine also does that. Oh, they both do that. They overlap. If you stress mother rats, they have less oxytocin production, all right? But you can reverse the effects of that by giving them oxytocin right into the amygdala. Clozapine and another drug related to it produce elevations in oxytocin in the brain, where as some of the more classic antipsychotics do not. So these medicines interact, right? All right. So this began leading us towards thinking, well, maybe we could use oxytocin in schizophrenia. We saw clinical symptoms that it might work on, that were residual symptoms from a good treatment, right? And it might lead us in the right direction, all right? So again, we didn't use the sublingual because many of our patients were intranasal drug users. We also used it for another reason. I mean, when you take a medicine intranasally, it doesn't absorb well if you have a cold, you know, and it's very hard to get intranasal medication in such a way as you can be sure of the dose. Most of it going in through the back of the throat. There was a hope that intranasal would go directly into the brain, which might not only not always work, but might have been a mistake in terms of where it would be effective. I think we just serendipitously fell into another way of going about it. Our early attempts to use it seemed positive, all right? There's also reports of successful use of sublingual oxytocin in obstetrics, initially to stop uterine bleeding, but also to induce birth in areas where they couldn't get the oxytocin in liquid form that had to be kept cold, delivered to distal areas. It's easy to get the sublingual made, and it's much cheaper. I think it's like 1/5 the price of getting the oxytocin done as an intranasal preparation. So for all those reasons, we tried that. And to let you know, here's a little cartoon of the tongue showing that there's lots of blood vessels under the tongue, and medicines given under the tongue absorb very nicely. And you know, we've gone over this with our staff here in the pharmacy, and they agree. And the form we have is prepared to allow this absorption. It's something else. Mary Brother Brown says, you know, when you do it this way, you bathe, because of the way the blood vessels go, you bathe the brainstem in oxytocin when it absorbs like this. You get a pretty high concentration right behind the tongue and the neck. And we actually found an animal study where it was given, and it showed blood levels in animals. And this is a study we really think we have to do in people, amongst even ourselves as the patients, to prove that you can get a reasonable blood level by giving oxytocin. And that's something we've kind of outlined to do. All right. So now we're getting to the meat of what we found, right? So to be able to present data and publish data, you have to have an IRB, which is permission, right? And so we didn't set up a study comparing treated to untreated patients because we felt we had to treat. So we treated patients in a certain way, and then we gathered all the patients we treated and reviewed our charts and our data to see what we had found. Now, we did these rating scales to see whether we were effective or not, whether we should move forward. So this was clinical data extracted from our experience, right? All the people we were treating at Michael's house were over 18. The average age was 25. Of this group, they were 30 Caucasians. One was of mixed background of this group. We now have a couple more people of mixed racial background because we now have closer to 35. We haven't analyzed all the data. They were all admitted with persistent psychiatric illnesses. So it's a private hospital. They all met criteria for schizophrenia or schizoaffective disorder. And when they got to us, they were all being treated with antipsychotics, second generation antipsychotics, sometimes with more than one of them. And they all had PAN scores, psychosis scores of between 76 and 130. That's pretty high. That's a pretty high score, right? They were also quite interesting in they're from middle class and upper middle class affluent families. 40% of them had family incomes of over $500,000 a year. They had very supportive families, all right? But they had all failed multiple trials of antipsychotics before we took them and before we put them on oxytocin and before we put them on clozapine. And they all stayed on clozapine for up to 6 months, some longer than that before we added oxytocin. There was a wide range in the amount of clozapine needed, and there was a rather wide range in the blood levels, but we were not treating to a level, we were treating for effect, measured effect, right? And we used, again, the same scale the other major research groups used, the positive scale, negative symptom scale, PANS it's called. I even spoke to Oprah, one of the developers of it, before we started doing it. We knew each other when we were younger. He recently passed away. He was great psychiatrist. So it takes time to do this. So we look for positive symptoms, negative symptoms, et cetera, general psychopathology, rated from 1 to 7. 1 is normal, 7 is outrageously bad. That means, you know, if you were perfect, you'd still have a score of 30. I've run around 38 day to day, but our patients are running again in the 70s to 100s, which is in a very, very ill range. Now, this is a very busy slide, which I know you're not supposed to ever use, but this is a slide that lets you, if you're interested, look at all the patients, all right? So their ages, their gender, what their diagnosis is in the third column, you know, schizophrenia, schizoaffective disorder, right? And also just to, you know, look, a large number of them have suffered traumatic brain injury in their lives, which is quite interesting in terms of what we found, right? The other thing is how many of them were treated for ADD at some point in their life. And you can imagine why, because if you had an illness that in which people were drawn, isolated, not very responsive, somebody might think they were suffering from attentional deficit disorder, right? You know, inattentive subtype. Also, they were all at some point in their lives on antidepressants. There's some data that being on stimulants may make it worse if you have this genetic vulnerability. Of course, the other thing is that column with the C's and the A's, that, you know, what is really rare is a young person admitted now who hasn't been abusing substances. Everybody uses cannabis. There's good data that this is not good in a subgroup of the population of our country, especially young men, you know. There's good data that it can worsen psychosis, but you can see that that's also very, very common, all right? And then there's the column of the PAN scores when they were admitted, but on medication. So they had been many months on antipsychotics and still with high scores. And then there's the raw scores of, what happens when we add clozapine, and 3 to 6 months later, usually 6 to 9 months, or actually more than 6 months usually, depending on them. We add the oxytocin, it drops again, and we have the percentage changes. I mean, the particular doses of the patients are just, I think of technical interest, we didn't see any pattern to it, all right? But you can see how we did it. So the wafers are either 10 or 20 international units, and so we were giving, starting people on 10 just to see if they were allergic to it, and then quickly raising the dosages to 20 to 60 international units spread over the day. Just put it right under your tongue, and it absorbs in a couple of minutes. In an effort to make the data on the psychosis effective, we've tried to break it up a bit. So P is for positive, N is for negative, and G is for general, and it's colored female and male. And you can see that, on a scale where there's, say 21 would be pretty sick, the averages were 20, right? When they were admitted, and then on clozapine, it drops, and then when you add oxytocin, it drops again. The same thing for the negative symptoms. There are more elements in the general scales, that's why they're higher. It's not that they're generally more ill, it's just that there's more elements, so the averages will be different. But it affects all three, and it works both in the men and the women we've studied. And so this is just putting it as percentage change. Now, I think the addition of the oxytocin had a remarkable change, but if you looked at this, you would say, oh, they just followed the same slope, right? Usually patients, they plateau out. So to continue getting better is interesting. So I'll show you a couple of those things, but I know any of you who are technically trained are going to say, look, they would have gotten better if you didn't add the oxytocin, right? But these are quite remarkable to get a further increase in negative symptoms getting better over a 6-month period to a year period. It could be clozapine took time, but I have never seen this kind of increase like that or so fast. And again, even in the general backgrounds. What makes it interesting to me, and again, I can't easily quantify it, though we're working on it, right, is what do you actually see when a patient is given oxytocin? And what you see is that they make eye contact with you, they become more social, they go out, they begin to, if they're at Michael's house, they begin to help with the cooking, they go to groups more, they chat with the staff, all right? And the staff notices it very quickly, all right? It doesn't necessarily show in a psychosis rating scale because it's a general behavioral scale that we have to, I think, develop to make better use of. And Dr. Ball and the other members of the groups have been working on this, so we're putting those together. The other thing that's also fascinating to me, just as an aside, is you see a patient, you ask if they hear voices or they see things, and they say no. And when you put them on clozapine, sometimes they say, yes, I do. What happens is the clozapine impacts their paranoia, so they open up to you. So you actually get a bleep sometimes as you move along in the overt scale of the psychosis as they're actually getting better. So there's a kind of dissociation where higher rating is not necessarily a reflection of being more ill. And then that would, you have to, again, figure out a way to systematize that kind of data to make better sense of it so you can make better decisions on treating patients. But what is really of interest to me over time is what's the sociological, emotional domain? What do people really perceive? Well, one thing is obvious. What happens within a year of being here, and being put on this? 60% of the subjects went back to school, 23% finished college, and 60% began jobs or returned to a job. That's an enormous increase in what the expectation would be. I've actually gone to the graduations of patients, one who graduated summa after having been out of school for years, You know, and that's really moving. You know, it's in it. Are they perfect? Are they totally normal? No, no, they're not. They still have PAN scores and they still are a little withdrawn, but they're living lives and many of them are working, which is quite remarkable. And again, not what I would usually see. These are parent statements, which to me are so powerful. And again, if we could systematize it, you know, it would make an incredible argument for what we do here. But so these are just some of the statements. I could, you know, give you 30 or 40 or 50 of these now, but I'll say it out loud. After years of being alone and isolated, he's gone back to college full time and is living alone. He is happy. He's with our family. She was so ill and tortured for years and now no voices. She is happy after 10 years of suffering. I mean, I know I chat with this young woman every month now. She comes to visit me or calls me, and it's true. It's now years that she has a life. She's in graduate school. She's in graduate school at an elite university, by the way. There's a change. He is sober and spending time with family. He can now live on his own after 5 years. So there's 5 years of being psychotic and isolated. It's the best she's been in 7 or more years. All right, sober, working. He is reborn, not locked up alone. He completed college. He was alone hearing voices, not making sense, and now he's completed college. He has his own radio program. Now he has his own radio program. He's teaching at a private school, and he's still on all of these things with a couple of little additions that I don't want to go into. Our daughter is back. She finished college. She found a job. She still gets angry, but that's her, you know. And we have our son again after years of being estranged. I mean, this makes me emotional when I go over these, but these are very powerful. I mean, you know, these young people are more responsive socially. They're able to go out. They get involved. They're more relaxed. They go to, one of the common things, they go to AA meetings, right? Because so many of them are substance abusers or substance users. And instead of sitting in the back alone, they move forward and they speak. They attempt to socialize. They go dancing. Some of them begin to be interested in having relationships. And that's difficult because that sets up anguish and pain and fear of rejection. But they're more independent. You know, I mean, one of my favorite patients, one of these girls said to me, I've noticed a real change. I said, what is it? She says, I can look at you. I can look at you. We put in a statement written by one of the patients. I won't read it all. I put it in there so you can get a sense. So to be clear, oxytocin does not give me a high. It does not elevate me to a disembodied, disconnected plane to make me apathetic towards the criticism, real or imagined, that I encounter. If anything, the effect is the exact opposite. Oxytocin plays a major role in keeping my mind clear from the noise of social paranoia. While I recommend taking it regularly throughout the day, depending on dosage, the few experiences I have had after forgetting to take it for over several hours have been instructive to show me just how much this medication improves my peace of mind. And she goes on, this young woman is now in graduate school in the city. She's actually a professional writer. You can sort of tell by the way she writes. I won't read everything, but she goes on. And if you're interested, it's in the slide set. She's an amazing person, and she was very, very alone for years. Just, you know, living a totally isolated life. So what's our key finding? Again, I'm beating it up a little bit, right? You know, the PAN scores improve, right? They improve by a certain percentage. The percentage is significant. It's significant as a number, but it's more significant what we see clinically changing, right? And it seems to be the combination to me is particularly powerful. I've never been able to get lots of people back to school on clozapine alone, even with other tricks. There's something about the combination. There, again, other things for another discussion that we sometimes add to make it even better, but this, to me, is pretty powerful. They go back to school, they graduate from college. I think 3 of them are now in graduate school. One has finished a degree in quantitative analysis. He has a job working for, it's like the equivalent of IBM, but and he loves it. And I mean, when we first met, he didn't speak, and now we chat. It's hard to follow the kids now as easily because of the COVID epidemic. So it's on Zoom and telephone. But now he looks right at me. He's another person who didn't look at me. And he finished a graduate degree at Columbia in computer science. If we had set up a double-blind study, we'd be in it for years and with millions of dollars, which we probably could never have raised. One of our board members, Peter Fonegay, Dr. Fonegay, suggested that we do something with a step design study that he's used successfully. I think it's one of the things we're considering if we can ever really get going and the world changes to being more reasonable. I've also been in contact with some of the research staff at New York State in the state system about what we would do. Now, I just want to stress this because it strikes me as being really important. State hospital patients, especially those treated outside the hospitals, are under high levels of substance abuse, but continuing substance abuse, non-compliance, extreme stress. It's really important that we get these people in, stabilize them, and then have them in a setting for an extended period of time where they're well cared for and sober before we can go on. I don't know if these interventions would work, right? And when we didn't have control. And I think that's one of the reasons why there's such a wide variety of data from other groups trying it. So the population of patients aren't as, I guess, rich or robust in positive things as we have. So the double-blind paradigm in this case makes it a little bit harder. Given our tradition, which is treating patients, it's I don't think we could do that here, at all. Our results are significant because these guys get better. It potentiates the clozapine, which is amazing, right? We have to develop better ways of measuring it and expressing it and passing it on. We've had so many patients respond well. I mean, and we haven't had a lot of problem with clozapine having negative side effects. I mean, most of them we've just worked our way through. There are a number of ways in which this may play out, right? I mean, from my standpoint, in my old age, I want to know, how does this work? What the hell is going on? We made up this little schema. So in the very center, we have Silverville Hospital, the acute unit, right? Patients come into the hospital acutely ill. They've come in usually after years of problems. They're caught up in a vicious cycle of anxiety, failure at school, social failure, drug abuse, social withdrawal, right? They failed treatments. They may be given treatments that even made them worse. So they look treatment resistant. They very often are abusing substances. They struggle with compliance, right? And then you have a behavioral reinforced belief that nothing will work. Hopelessness and helplessness sets in, and they get to us, and the inpatient staff does a great job of giving them a sense of hope and moving them on. And they get to us. Well, they get to us on Risperdal or Zyprexa or Abilify, sometimes 2 medicines, sometimes 3 or 4 medicines, right? And they are partially responding. So they would meet criteria for treatment-resistant, resistant schizophrenia, multiple failures, still with high PANSS. So PANSS score is above 80, right? And we spend some time getting to know them, and we start clozapine. And over 8 weeks, we get a 30-point decrease, right? That's amazing. The FDA would approve this as it was a new drug. They would, they'd speed up the approval. In fact, if we did it as a double blind. we be on the circuit selling that drug and being paid $10,000 a lecture, probably, right? if we had developed this medicine, even though it's 50 years old. But then they get better. They often leave the hospital. Sometimes they come back and forth, you know, but they plateau, better, but not good enough. And usually 6 months out or so, but a minimum of 3 months, we've added oxytocin and we drop another 10 to 20 points. Doesn't sound like a lot, but that's a 10 to 20 point in a range where it's already compressed. And that's the critic on a sort of a, you know, looking at it from just a number standpoint, right? That's an amazing decrease because it leads to a change, right? That they can get out and do more. Why do we have such a good thing? Good patient selection, good histories, lots of family support, great treatment setting, all right? An incredible treatment team, worked together for a decade, most of them, right? Totally trained at the highest level and totally dedicated. I think the oxytocin preparation and the route of administration is also important in this. And maybe I'm biased, maybe that's why we gotta get raters who are not me and not our direct staff to do this, to see whether or not I've been diluting myself. So the kinds of things the patients say is they don't notice anything, or they just say, oh, I finished the semester. It's the first time after being in that school for 5 years, they finished the semester. One of the kids went back to Bonnet and got all A's last semester after having been expelled from school. I mean, she called me up in tears. I mean, she's like, oh my God, I can work, right? They're less anxious, less dependent, easier. And because they get a little bit like Buddha, they feel good. They feel good in their belly. They feel more at ease. These are not random patients, right? They come from really supportive families. I'll go through this. I don't want to repeat it over and over again, but there's something about it. The clozapine may clear the pathway for the oxytocin to work, right? How many minutes? 5 minutes? Okay, so I want to be able to say what I think is going on. The clozapine can act to protect brain cells from toxic effects, as well as blocking psychosis in the critical areas of the limbic system, just like other antipsychotics. But what's different is it blocks toxicity. And it blocks toxicity in the critical areas of the hippocampus where there's regeneration of cells in adults. So adult neuronal neogenesis in certain critical parts of the hippocampus. When the oxytocin goes in, it stimulates those cells more, protects them, and actually increases their rate of sending off axons and making dendrites. So they connect to the septal area in the nucleus accumbens and reinforce connections to the amygdala. Those are all parts of the brain involved in memory and emotional control. I think what's happening is the combination has an enormous facilitation of the ability of the brain to heal. And that healing is not in any way, you know, sort of a minor thing that, oh, it's a little better. I think it actually increases rates of regenerative processes. Oxytocin looks like it can cause regeneration of processes in muscle cells in cell cultures. I think that is what's going on. Again, I'm trying to draw it up and put it into some kind of more detailed fashion. There's some slides here with the why I think this and some of the papers I've read from other areas which are in the slide set, so you know where my mind is going about the relationship between the nucleus accumbens and the septum and how that might work. But one other thing is that I keep showing the Buddha, the relaxation response. That is probably due to the cranial nerves causing a relaxation response through the thorax and the abdomen, relaxing the heart and causing a feedback into the brain that life is okay. Just like a mother having given birth, being the brain and her internal organs being bathed in oxytocin. I think it may almost work like that there's a peacefulness. I'm not going to go over it. I have 1 minute. I can stop. Should I stop now? I mean, I want to, again, thank everybody that's helped us. And there are slides here about some of the scales we're developing and things we're doing. And I will end with the Bodhisattva himself, at peace. I have a photograph of my latest granddaughter looking like this. Happy with life, so the newborn. Thanks very much. I think we're ready for questions now, okay?
Fantastic.
Amir, are you there?
I am here. Sorry. There we are. Okay. We have a lot of questions, but I wanted to ask Dr. Gerber if you wanted to say anything about, to start off the bat.
I would. I'm just worried about echo.
Oh, is that it?
Maybe I can you hear me through Rocky's computer?
Yes.
All right. So what I'm going to say is I've been looking at the questions, and they're wonderful questions that express all the excitement and appreciation for Rocky's work. So I don't want to take any time away from that. Rocky speaks for himself. You can see why we're so lucky to have him here, and why families speak about Rocky in ways that I've never heard them speak about anybody else. So I'm gonna turn it back to you, Amir, to share the questions, because I'm interested to hear his answers on lots of them too, and just tell you that you will hear more from us, because we're going to do more. We're going to help support Rocky do more in this youth center, and we'll be back when we have more. But for now, over to Rocky to answer some of these questions.
All right. So let's start off with a question that I think is a very good question. It said, if clozapine is giving relief to patients but making them tired, which can add insult to injury with negative symptoms, can you lower the clozapine if you add oxytocin? Is that something that is possible?
Yes, I think so. In fact, one of the patients that isn't in the study, who's been on it for years, is now a doctor. So it's one of the first people I tried. And I have him down to almost very, very little oxytocin, and he functions at a high level. But the other thing, I was alluding to tricks. We use other medicines later on to increase the focus of attention. We use the medicines that are used to treat narcolepsy, like Nuvigil and Provigil, mixed with it, and other little tricks that seem to work. But one of the things, of course, we're doing is we follow people over time, and we try to use the minimum dose that works. And that's why sometimes if you look at the final slides, you have this huge spectrum of dosages from 50 to 850 actually in all the data sets we have. So we can get the dose down and people still work. It's a big thing about, kids in school, which is getting them so that they can really focus, especially for class in the morning, because, on clozapine, people sleep late. But it's something else we've been doing is trying to work out, protocols for treating that.
On a related note, someone asked whether or not we have data looking at to see if oxytocin affects the serum clozapine or norclozapine levels, or the ratio.
I could dig it out, I guess, because I have clozapine levels from about 40 patients who've been on oxytocin for an extended period of time. So I have all those clozapine levels initially, once a week, once every other week. So I have them, and I might be able to look for an inflection point. All right. But since there's another thing going on, which is with lowering dosages. We're not very often, we don't stay at a stable dose necessarily, and but we've been following lots of things, and I've never noticed stuff, right? It's never struck me, but I'd have to go through it. I have a funny feeling, that it may lower the levels because of water balance, because the oxytocin is like, vasopressin, arginine vasopressin, right? But I've sent out on all these patients repeatedly creatinines, UAs and stuff, looking for an obvious effect, and I haven't seen it. But it's probably buried in the data, that I haven't collected yet. Well, extracted is the better word.
Yes. And one of the questions someone asked is about side effects, like why patients would resist oxytocin. And I mean, I recall, Rocco, we had this conversation with Dr. Mercedes Perez Rodriguez at Mount Sinai, who, you know, she's done work using oxytocin in patients with personality disorders, borderline personality. And she said, of all the people that she studied, she never saw anyone have an adverse reaction. And I don't think you and I, in our recollection, anyone had a negative reaction to the oxytocin sublingual.
Yeah, but there is something that was negative in somebody. And it's interesting to me. You know, what I want to do someday is go to a wedding of one of these kids. You know, I want them to get married. My kids, a couple of them suffer like the rest of us, you know. But that one of the patients didn't like the oxytocin. He stayed on it for a couple of years and then stopped it. And I was trying to figure out why. He would say, I don't like it, I don't. And I think it made him want desperately to be related to other people, to girls and to date. And it wasn't working for him. I think it was negative in that it was easier for him to be, you know, less desirous, you know. And I'm not so sure because he finds it very hard to talk to me about it, you know.
Yes.
At the same time, I think that that's what it is, you know. Because occasionally somebody wants to stop and then they go back on it. I mean, in bed, like it depends on how they respond to that. But I think it's easier for the girls to stay on it than some of the boys sometimes, because the boys don't feel it as it's not as present or an experience. Sometimes the girls feel really good on it, and the boys say, "I don't know, I seem to be better." They say something like that, you know. But I'd have to point out to one of the boys that, you know, you now talk to me, and they're surprised by it. Whereas if the girls, they know they're talking to me, they say, you know, it's easier to talk to you. The boys, I have to point out to them, you're easier to talk to. It's a different perspective. I think that's a gender specific kind of thing, I think. And girls like to talk, so they like oxytocin.
And there's so many amazing questions here. We have like 30 questions. I want to try to get as many as possible. One is from, is actually asking about whether we can measure blood levels of oxytocin. And this is an ongoing area where we're actually trying to do some pilot research on this. Maybe you want to talk about that. And like,
we really want to raise the money and to do it and, you know, work with Dr. Mercedes Perez and other people. But the question is, the blood level might not be a reflection of its therapeutic effect, because the blood level is not the brain level, right? And
yes,
it's in the brain. And it might be interesting to get some kind of, not just blood levels, but get some kind of psychophysiological measure, a covariant, like an EEG thing or a nerve conduction thing, or some measure of heart variability that would reflect the sympathetic autonomic nervous system interaction. You know, that might be really interesting. But we need, because, you know, Dr. Enso, at the head of the NIH, NIMH, he wants measurements. He wants target, right? And if we're going to convince him that we're up to something, we have to get a good measure. We need a good measure. And he wants a brain measure. So what does he want us to do? Get a functional MRI machine in the basement?
We can make it happen.
just to get him to, you know, smile. I don't know. But I think we need some collaborators who know. I mean, it's when you read through the literature, he's very demanding about funding now. You have to know it, right? He's very, very demanding. And, you know, he doesn't trust me.
Yeah.
But what else?
Well,
yeah.
I have a good question from Dr. Richard Francis, former president of Silver Hill. He asked about if you think it would be more helpful if the symptoms were given when patients are prodromal, which is interesting. Obviously, I don't think we've studied that yet.
We haven't studied it, but it may be buried in something. It may be buried because, you know, when you look on the internet, there's this whole world of people pushing oxytocin around, selling it. I don't know what they're actually selling, if it's oxytocin or not, you know, but so it may be buried in something. Now, it seems to be like Colorado, where the kids are smoking tons of marijuana, they're also using lots of oxytocin. It may be buried in emergency room data in Colorado. I think it would work, Emir. Rich, I really think it would work. The reason I think it would work is that relaxation response, right? And the feedback. You know, when you read Arrietty, the old textbook on schizophrenia, what was that, 1961 or something? It was in the library at Payne Whitney. I read the book. You know, Herb Weiner, who was my mentor, a great man. He was also Dr. Ackerman's mentor. Weiner made me read Kreplin and Boiler and things like that. It buried is the whole idea of psychotic anxiety, or the psychotic state, inducing a state of anxiety which was destructive and toxic. I think if you could interfere with the feedback of that toxic anxiety, that would maintain social relatedness, that would be, if not curative, would be protective in some fashion. I believe that, right? But it would be something to think about. Maybe it should be, you know, in my own head, I've been trying to show how this works for the worst patients, right? So I literally took a sample, you know, of the worst, right? It's a rarefied sample or an enriched sample.
Yes, enriched sample.
An enriched sample of the worst cases to treat, because we were doing something that we had to justify doing. It wasn't, you know, we weren't just throwing it around aimlessly, but it might be an early intervention. Yeah.
So one of the questions I thought was interesting is how soon before you would add, like, would you keep someone on clozapine before you consider adding oxytocin?
Yeah, that's a variant of those other questions, right?
Yeah.
So
Yeah.
the reason we took the worst patients, we waited months because there's a literature that clozapine continues to work over months. We waited and waited. We waited for it to plateau. We thought it would, you know, but we don't know for sure, right? You know, and then we added it. I mean, I always say I have to think about treating a patient the way I would think about treating my own son or my nephews or nieces, right? Which is what would I demand to be done? And at this point in my life, I would demand an earlier intervention, which makes it hard to collect data, which is why it's setting up a paradigm for study is difficult. You know, I mean, again, in our setting, right? I would say, I wouldn't wait 6 months. It would be ridiculous. Why keep a person even in a modulated state of psychosis for 6 months? Why would, if you thought you could impact it, right? Losing
Yes.
another year of school, another year of life is catastrophic.
Yes. So one of the questions I see a theme here that people are asking about whether oxytocin can be used with other antipsychotics. And of course, you and I both know, Rocky, having done a lot of literature review, there's a whole host of you know, systematic reviews and meta-analyses of studies where it has been used with aripiprazole and other antipsychotics. There's some newer antipsychotics on the market that people ask about, but obviously these haven't been studied with oxytocin because they're fairly new. But so I guess the question is, can it be used with other antipsychotics? And I would say it has been studied.
Yeah, and so that's the interesting thing. I think we got cleaner data because like there's so much, when you look at the actual data, right? It's so there were patients for whom it worked and there were patients for whom it didn't work. And so they were presenting average data saying it's not an effective treatment, right? So so for about some patients that got worse on it, it's like the old graduate school thing, 1/3 get better, 1/3 get worse, 1/3 nothing happens, right? And since they had it was a large number of small studies with a heterogeneous population on different medicines, they were losing the signal, right? And that's why I said, if you with intranasal, you're not sure of the delivery, right? You're not sure of the site of delivery. Where with sublingual, we were much more sure of delivery, all right, into the vasculature as a whole. And we had patients who were stabilized we knew them, we were following them, and we were following them. We weren't just checking stuff, right? As we were responding. So that enriched sample, that was not an enriched sample, that was an enriched treatment environment, right? And so we cleared the signal, we got a clearer signal, or we did something that we weren't admitting to that worked. It wasn't the medications, it was something else we were doing, which is the fact that we were spending some, right? It was a general effect, which is why, again, we need raters who aren't us. All right.
But I do want to respond, Rocky. One of the criticisms we faced on the paper that the case report we submitted to the Journal of Clinical Psychopharmacology is one of the reviewers said, well, there was a study that compared oxytocin, intranasal and sublingual oxytocin, and like measured blood levels. And we mentioned, because there were research studies that show we cannot take stock of what the blood level means. So
blood level doesn't determine fact. Yeah.
Yeah, exactly. One of the other questions that I don't know how we can answer this, it's a very difficult question, is that do people develop a tolerance to oxytocin over time?
Yeah.
Yeah.
Well, but tolerance to some things and not others.
Yeah.
I mean, once you begin reading the general physiological literature, you find that it has effects on almost everything, right? And membrane potentials. I mean, it is a widely distributed system. I mean, you have oxytocin receptors all over the place. It's like in my PhD defense, somebody tried to take me down because I didn't mention that there were dopamine receptors on the kidney, and someone else in the room had to key me in. He said, "Get out of the brain, focus on something." Yeah, these things were complicated biological systems, right? And so when you start, it was only like a week and a half ago, I found the paper on innervation of the blood vessels of the heart. I found enough strange things over the last 18 months when we worked on the reviews, right? That it's everywhere. So it could be that the effect, is on this in superior cervical ganglia, the interneuron in the superior cervical ganglia, or on the kidney, or on, the vasopressin 2 receptor, or something like that, right? I mean, that's how science works. I mean, but right now we have an effect and we have to figure it out, where I don't know the answers to the complexity of that, but I do know that you can get burnt. So my personal story is we had a paper speeding up rates of recovery from brain damage in an animal model. And it seemed so interesting. We submitted it to Science, and the reviewer said, "This is really interesting. If it's true, we should publish it, but don't publish it." So we submitted it to Nature, and they published it in Nature. But so there's strange, you don't know. It's like this tetimeyism, right? You don't know for sure. There's something there that you don't see clearly, right? And maybe it'll take us down a blind alley like so much has in science over the last 500 years, but maybe some real good will come of it. At the very least, we've worked hard on these 60 odd patients, and lots of them have done better. So Dayenu.
Yeah.
Right.
One of the other questions that people ask about are, doses and how do you obtain it? And I just want to be clear, just for the sake of total disclosure, this is not an FDA approved treatment. It's something that's being done off label and investigative fashion. And, Rocky, I guess I can tell them we obtain it from a specialty pharmacy, the sublingual tablets, correct?
We have it made. And there was a whole another literature from the pharmaceutical industry on how to make sublingual absorb, and the reason they were doing it was not to treat schizophrenia. So how to deliver effective drugs to non-industrialized parts of the world without electricity to keep medications cold. So how can you treat women giving birth, in Central Africa or in Indonesia, right? And so that's why these things were developed. So we sort of fell into these. Oh, we can do that. Yeah, that's easy. We ship that to to Malaysia, sort of like. And there's a paper in the South African Journal of Obstetrics on induction of labor using sublingual, what the dosages are and how to do it. Right? They can it doesn't break down in humidity and heat.
Yes.
You know, but there was a whole world of information I had no inkling of until we began reading it and trying to figure out what to do next, you know.
But to be clear, we're using doses that are far lower than they would use for Pitocin for induction of labor. We're talking about,
I think 100 to 1,000 less.
yes. And I recall in the paper, we were giving doses of, what were the doses we've been using, Rocky?
We use up the research, other people intranasal were using 24 to say 60, and we were starting at 10 and going as high, you know, and some people, they took it up to 120 because they did much better on it. I mean, one of the person taking the most has a job on Wall Street. He went back to school, graduated from Wake Forest, you know, after being out of school for several years, I think, has a job on Wall Street. He finds that if he has to work late and do certain kinds of things, you know, it helps to take a couple of extra dosage of it. And I say, why not? You know,
Yeah.
He said, I'm taking so many blood tests on him, trying to figure out what would go wrong. And so what I say to the kids, I call them my kids, I say, you're going to tell me what works and how to use it. We'll go through this together, and people will have different ranges of effective dosages like in any other medicine, you know.
Yes. And the dose we used for the patient in the study we published was 20 milligrams a day, Rocky.
We started at 20 and went as high as 60, yeah.
Yes.
Not milligrams, international units. It's a
Yeah.
strange conversion.
Yeah.
Yeah.
So one of the questions that has been asked by a few people is like, what about randomized placebo-controlled double-blind studies? I'm like, well, that's one of the things we have to work our way up to, right? This is preliminary pilot data. On a personal though, Rocky, I think we talked with not only talking to Dr. Mercedes Perez, but I talked to a colleague and friend, Dr. James Morrow, who runs the depression and the ketamine research at Sinai, and he said that the NIH, as you said, is really resistant to this research because they're sort of like, well, how do you show the oxytocin is having an effect?
Right.
Yeah, that's a tricky part. I mean, clinical improvement, yes, but this is one of those things where you can't really measure blood levels. We're not going to get CSF samples on people, so it's going to be a challenge to do this. But I'm glad that we have people interested in doing the research.
Yeah, you know, it would be incredibly if this leads to something, it will be very expensive to do it the way it would have to be done to, you know, convince our senior colleagues in Washington. All right.
Yeah.
So it's a matter of, you know, what risks are willing to be taken. And there are things here I couldn't, you know, I couldn't do the proper settings in the functional MRI machine to do it, or make the tracer, right? But you know, so people have different functions, different specialties, but we think there's something there. But there are things we might do, and they might be, you know, covariance, physiological covariance, or endophenotypes, right?
Yes.
We got that right in the multiple choice. Endophenotype. Right. You know, I mean, this is not translational research. We're above that, but it's not a high-level double-blind placebo-controlled study, which is the gold standard of our profession, right?
Yes.
So we're the infantry in the trenches still.
Yeah. And to be clear, because we got asked a question by a former colleague of ours, Carolyn Groby, we both know and love. She asked about like how long do you keep patients on this, because they get back to their lives and they're functioning, and maybe you could speak to these patients that you mentioned. They're still taking the clozapine and the oxytocin, so this is long term. I think this.
Yeah, but some people have stopped it and seen better. I mean, one of the people who was a famous Michael Sal's patient who came to us grossly psychotic, having been treated with high dose ketamine for an extended period of time in ECT. And we got her on, you know, Clozapine and oxytocin. She got incredibly better. She had been doing a Ph.D. in computer science and number theory. And she still had deficits. I think, by the way, marijuana and PCP and ketamine are a bad mix. I've seen a couple of patients with very difficult to treat, had ECT and long, you know, both abuse and treatment with, you know, ketamine. And but she felt she didn't need it anymore. And you know, she was good. She was all right. She was happy. But she stayed on the clozapine. So it depends. And I think everybody's different. I mean, it's a clinical decision, right? About what's best for any given person. So it's not to me, it's not a cookbook over here that everybody has to follow. You got to look at the patients, because as many of you know, I'm an agnostic about diagnostic systems, right? I don't think there's a disease, schizophrenia. I think there's a spectrum of disorders that are called schizophrenia, and they have different underlying pathophysiologies and neurobiochemistries. And so, and that's another reason why having an enriched sample of a certain kind of patient may have allowed us to see things that were washed out in some of the data, you know, from the people in Los Angeles and in Italy too, right? And
Yes. Well, I want to point out a question some people asked about, like, they won't talk about, can we do studies in our group? We're talking about doing it at state hospitals or VAs. What's interesting is that we can notice, you know, given the resources of the patients, we can get them back into their lives. And these are people who already had pre-morbid high levels of functioning. So it is interesting to see how this research might translate into other populations.
yeah.
But I think we have time for one quick question. Maybe not a quick question, but it was asked by a few people, that what about the effects of substances? Like, people ask about cannabis and psychosis. And I mean, we've had Dr. D'Souza from Yale talk a lot about that. But like, how do you consolidate that research with the work we're doing on oxytocin in terms of people's psychosis and their functioning?
Yeah, you know, Dr. D'Souza to me is a prophet. It's another team liaison, right? You should listen to our brother, right?
Yes.
Which is that there are people in this world, especially young men, for whom use of, you know, cannabis, especially high potency cannabis, can be catastrophic. And that's why when I pointed out that column along, right? I mean, we could make slides of that to stress. I didn't want to stress that. There's that column showing how many of these young people had used cannabis in very high dosages, right, over time, and how dangerous that is. I mean, and so I kiddingly say, you know, I was at Woodstock, so you know, I don't come about my opposition to legalization, you know, easily, but I think it's a dangerous thing. And at least they should be teaching, people should know that if a child is vulnerable, getting into cannabis might lead them down a bad path, which is also like, so many kids get diagnosed as ADD, inattentive ADD, and get put on stimulants. There's data that might also be difficult, you know, dangerous, lead to difficulties long-term. And we live in a society in which, you know, improving functioning through stimulants and calming down with sedatives is part of the culture now, and it may lead to problems. And again, people should have Dr. D'Souza teach them about this, because he's a real expert in this, and I stand with him on this point.
Well, he came last year to Silver Hill, and we'll bring him back again to talk again about it, definitely.
I think you got to bring him into the schools.
Yes, absolutely.
I think you have to bring him into the governor's office. You know.
All right, we're coming to the end of our time, Dr. Marotta. It's been a pleasure. I want to thank everybody for attending, and sorry we couldn't get to all the questions. There were so many. I've never had this many questions, so that's a testament to how, you know, interesting a topic this is, and how much excitement there is about this research. So thank you, Dr. Marotta. Please, you'll be able to do the survey to get your CME credits, and I think, Dr. Marotta, maybe we'll figure out if we can make the slides available.
Yeah, I need some credit. Do I fill it out too?
Yeah, we'll make sure. Well, I'll help you with that, Rocky.
I'm getting old. Thank you. Thank you.
You.
It's a pleasure. Bye-bye now. Does it just go off?